So we are very happy and delighted to welcome you everyone to this Dietopedia of Community Nutrition Forum. It is a continuous education program happening every month. This month is a special event because it is September National Nutrition Month, and daily based webinars and offline sessions are going on everywhere across the India. So we welcome you all. Community Nutrition Forum is the platform created during 2021 for basically we created for food educating the patients, because during Corona there was a hype in health factors. So everywhere there were infodemics and patients were misleaded with so many misinformation. So that is when we dietitians thought it is our responsibility to educate society on certain apps for fat diets and other aspects of health and food. So we started this community, like-minded dietitians together started this community in 2021. In 2023, December, we registered it as per the non-government organization procedures. Now CNF is a registered body in Kerala for qualified dietitians. So I invite our treasurer, Jyoti James, to give a welcome address.
Thank you, Sripriya. Good evening, everyone. I'm delighted to welcome you to the Community Nutrition Forum's National Nutrition Month 2024 celebration, along with our Dietopedia. Today, we gather as a united community of dietitians, health professionals, and advocates, all dedicated to the vital cause of nutrition education. The Community Nutrition Forum was initiated by dietitians from Kerala with a clear aim to engage in community activities that support the eradication of nutritional literacy by fugigating the general public. This initiative is not just about educating others. It's also a platform for empowering dietitians through continuous nutrition education and skill upgrade courses. Additionally, we are committed to scientific research activities that enhance our understanding and practices in nutrition. As we focus on the theme of this year's National Nutrition Month, let us remember our mission. This month provides us with a unique opportunity to engage with the public, raise awareness, and empower individuals with the knowledge they need to make informed food choices. I want to extend a special welcome to our esteemed speakers. First of all, I would like to welcome Dr. UNNIKRISHNAN V, who will speak on sarcopenia in critical care, nutritional needs and management. And secondly, Dr. Priyanka Rohatgi, who will cover dysphagia management. Their invaluable insights will guide us today. I would also like to acknowledge the hard work of our organizing team, our president, Sharon Thomas, ma'am, and Vice President Uma Kalyani, Secretary Dr. Sripriya Shaji, and our Joint Secretary Sonia K. Joseph, Treasurer, myself itself. Together we learn, unlearn, and relearn, strengthening our collective impact on community health and nutrition. Thank you for being here, and let's make this National Nutrition Month a memorable and impactful one through Community Nutrition Forum. Thank you. And I welcome.
Thank you, Jyoti James. It is time for our interesting session on sarcopenia. I welcome Dr. UNNIKRISHNAN. And before he starts with the session, I also want to give you a brief introduction on Dr. UNNIKRISHNAN. So Dr. UNNIKRISHNAN has DNB, FNB, and IFCCM. His affiliations is gold medalist in IFCCM exams 2021, presently working as a consultant and head of critical care at Travancore Medical College, Kollam. His areas of interest are obstetrics and trauma critical care, advanced hemodynamic monitoring. He was initially working after completion of his training in critical care. He was working at KIMS Health Trivandrum for 4 years before joining the present institution. We welcome you, sir. Please take over.
Thank you, ma'am, for the kind introduction. At the outset, let me thank Team Dietopedia for having me here, because to be frank, our online sessions are almost not happening, because whenever we plan something, we hardly get 5 people to attend these sessions during these peak hours. And I was seeing the participant list. I think it crossed 30. That's a great number. It is a great challenge for me also. Okay, I think I'll share my screen.
Yes, sir, please.
Microsoft. I think the screen can be seen, right?
Yes, sir.
The audio is also
Clear.
Correct, right?
Yeah, clear.
So, the topic which was given to me was sarcopenia in the critically ill, addressing the nutritional needs and how to approach it therapeutically. So, sarcopenia. Let me go on to my first slide. We as intensivists, usually the most common case we deal with is sepsis and septic shock. With the advancements in therapy, with advancements in guidelines, we have the mortality sepsis is actually coming down. So the death in the first year, which was around more than 50%, is actually coming down. But what about the 6-minute walk test at 5 years? What is a 6-minute walk test? At 5 years, when a person is asked to walk for 6 minutes, he should walk at least 400 to 700 meters. So, if a person who has survived an episode of sepsis, what is a 6-minute walk test at 5 years? It is actually only 70% of the people who are affected with sepsis are unable to perform the 6-minute walk test at 5 years. So, my
Can
question
you
is:
make your
are we
screen
creating?
full screen?
Is it full? Let me see. Yes. Now it's full screen, right?
No, it's in the PPT mode only.
I changed to full screen actually.
Okay. But it is still in the PPT mode.
Here it's full screen. Let me see once.
No issues. Please go ahead.
Shall I continue?
Might
Is
be
full
the
screen?
viewers using in phone, it will be difficult. Okay, sir. Please continue.
Okay, so my question is: are we creating survivors or victims by saving lives of sepsis patients? We are thinking that we are creating survivors, but actually we are creating victims. So how can we reduce that? So this is an article from NEJM about ICU acquired weakness and recovery from critical illness. Basically, sarcopenia is of two types: primary sarcopenia as well as secondary sarcopenia. Primary sarcopenia is one that the person already has because of his age, comorbidities and all. It's a secondary sarcopenia or the ICU acquired weakness that is relevant when a person lands up in the ICU. So this is the numbers I mentioned are.
Excuse me, doctor, 1 minute. I think the slides are not moving.
Slides are
Maybe you
not
can, stop sharing and once again you can start sharing it so that it will come in. Yeah, now it's moving. Can you just try stop sharing it and share it again so that it will become full screen?
Let me see. Stop. Now is it okay?
Now it's moving, but it's not yet in the full screen mode actually.
Now is it full
Yeah.
screen?
No, not yet. You have clicked the slideshow mode, right?
Slideshow. Yeah, slideshow only I clicked.
Yeah, but now it's moving, but it's not yet in the full screen. But it's okay. It's moving now. Yeah. No, not yet.
Slideshow only. If the slides can be seen, shall I continue?
Yeah, you can go ahead.
Okay, so it is a secondary sarcopenia that is of much relevance when a person lands up in the ICU. So I want to go by like a case-based discussion. Here we have a 70-year-old man who's named James. He is a person who he's 70 years and he has no much of comorbidities. He lives a healthy lifestyle. So he lands up in the ICU with a pneumonia. So my what will happen to a person because of his age? What will happen if the patient age crosses more than 70? After the age of 70, the person will lose 8 to 5% of muscle mass per decade. So by the time the patient has reached 70 years, he has already lost 24% of his muscle mass. That is at least 1/4 of his muscle mass. Now, take this young person who is 40 years old and when he transitions into a 70-year-old. between the age of 40 to 60, you lose at least 15 to 23% of your muscle mass. So, yeah, if this is known as age-related sarcopenia. With aging, you lose your muscle mass and muscle strength. So this is a graph showing how the muscle mass and muscle function progresses as you age. In early life, up to the age of 40, your muscle mass and muscle function increases,
I'm
improves.
sorry to interrupt, but we are not able to see the slides moving at all.
And now it is moving. Yeah. Now it has come to the next slide.
Now is it moving?
Yeah, now it's in the 7th slide. 7th one.
Now it's moving, right?
Yeah, now it's moving. Yeah.
Yeah.
During the session, like it gets interpreted, stopped. I think you can go in the PPT mode itself so that the slide will move better.
Sure. Now it's moving, right? So, so by the time a person reaches 40 years of age and enters adulthood, the graph plateaus itself. So there is no much increase in muscle mass or muscle function. And by the time the patient reaches 70 years of age, there is a gradual decline in muscle mass and muscle function, but it usually does not go below the disability threshold. The flat dotted line I have drawn, that's a disability threshold. And this is known as age-related sarcopenia. So what is disease-related sarcopenia or nutrition-related sarcopenia? Suppose this particular person, as he ages and he contracts an illness, be it a sepsis, be it a pneumonia or a urinary tract infection or a meningitis, whatever, due to whatever reason he lands up in the ICU, this graph comes down to below the disability threshold. That is where the disease-related sarcopenia or nutrition-related sarcopenia occurs. So we have two types of definitions: age-related sarcopenia and disease-related sarcopenia. So an elderly person catches an infection. So both these interplay of events will happen significantly. So this is a trial paper which was done came as early as 2013 in the journal JAMA. Actually, the incidence of acute skeletal muscle wasting in critical care. You could see that as the days, by day 1 itself, the skeletal muscle starts getting wasted, and with the occurrence of organ failures, be it kidney failure, liver failure, brain failure, heart failure, as the number of comorbidities increases, the incidence of sarcopenia rises exponentially. And by the time the patient is there in the ICU for 7 days, there is significant necrosis that is happening in the muscles. You could see the muscle biopsy, there is significant necrosis in the muscles. So how to quantify sarcopenia? Is it based on BMI? Is it based on body mass index? How is it body mass index different from lean body mass? I know that you all know it. Body mass index is a ratio of weight in kilogram divided meter square. It takes the component of fat into account. But actually, it is a lean body mass that should be taken into play. Once the lean body mass falls, there occurs a 10% loss in lean body mass. There occurs impaired immunity, which leads to increased infection. Once there is a 20% loss in lean body mass, there is decreased wound healing, weakness, infection, and thinning of skin. And once a lean body mass falls to less than 30%, the patient is too weak to sit, pressure sores develop, and there is no wound healing. And when the lean body mass falls to less than 40%, usually patient dies, usually from pneumonia. So what if a person in the ICU who has a lean body mass of loss of lean body mass of more than 30%, you take the patient for a surgery, you will almost always you will not get a good outcome because the wounds may not heal. There is increased predisposition to infection. So you have to try to improve the muscle mass, muscle strength, and muscle function to at least 10 to 20% loss in lean body mass, so that you could get good recovery from this surgery and all. So this is a slide showing the importance of malnutrition sarcopenia syndrome. So whenever, because of the critical illness, the person has a reduced nutrient intake, there occurs a reduced physical function, which leads to reduced muscle strength, muscle mass, reduced body weight, or inflammation. All these cyclical play of events happen. Hello? Because of which there is anabolic resistance, reduced blood flow to the muscles, there is mitochondrial failure, and there is significant insulin resistance, and everything under the sun you will get. So this is known as malnutrition sarcopenia syndrome. This whole interplay of events happen on the patient and leads to a bad and detrimental outcome. So how do we, with this introduction, how do we define sarcopenia? As already mentioned, BMI does not have an impact, because lean body mass is different for patients with different BMI. So it's a lean body mass which should come into play. And what are the how have the definitions evolved? So from the year 1989 itself, multiple definitions have come into play. And later, as of now, we are following the sarcopenia definitions outcome consortium definition, which was published in the year 2020 by Hassan et al. So you have a risk stratification scoring, which is called the SARC-F score. It is basically for the OPD patient, not for a patient in the ICU. By S, you are assessing the strength, how much difficulty you are having lifting, strength you are assessing by lifting. Does the patient need assistance in walking across a room, and how much difficult it is for the person to rise from a chair, and how much difficulty you have to climb a flight of 10 stairs, and how many falls the patient has had in the last year. So if the score is more than or equal to 4, the patient carries patient is probably having sarcopenia. So if you are able to do this, SARC-F score is a good score to assess for the risk factors. So how will you assess a muscle strength? In sarcopenia definition, 3 components we are assessing: muscle strength, muscle function, and muscle mass. How will you assess for the muscle strength? You can assess a muscle strength by doing a hand grip dynamometry or a chair stand test. How will you assess for the chair stand test? You ask the person to sit in a chair and not leaning on the back, and keep the hands crossed kept over the opposite shoulders, and ask the person to stand up. And if in 30 seconds, if he can do 14 times sit-ups and stand-ups, he has a good chair stand test. And we all know our parents, when we were kids, they used to carry us around and used to play us with us a lot. But as they age, they are unable to do this. This because of sarcopenia. If we go and do a chair stand test on our parents, they may not be able to do it. Okay. So chair stand test in 30 seconds, it has to be more than 14. And if you're doing for 12 seconds, it has to be more than 5 ups and downs. And how will you assess? This is how you assess for muscle strength. How will you assess for muscle mass? Muscle mass is assessed with the help of bioelectrical impedance assessment by the use of CT scans, MRI scans, and DEXA scans. In CT, you will assess the L3 muscle mass at the level of L3, and it is quantified in terms of centimeter square by meter square, and it is done at the level of L3 level, third lumbar vertebra definition. So sarcopenia, by definition, it is hand grip strength of less than 20 for women, or less than 35.5 for men, or a gait speed of less than 0.8 meters per second. So that is actually definition. How to assess it in a sick patient? Presence of any of the following clinical conditions. If you could see, most of our ICU patients will be having at least one of these mentioned here, or combinations of these mentioned here. A functional decline or limitation, that is an unintentional weight loss, depressive mood, cognitive impairment, repeated falls, and malnutrition. If the patient does not have the above mentioned things, does the patient have any chronic illnesses like heart failure, COPD, diabetes, CKD, or if no clinical conditions mentioned above are present, you go and do a calf circumference. If it is less than 34 centimeter for males, or less than 33 for females, or a SARC-F more than or equal to 4, you could say that the patient is sarcopenic. As already mentioned, the muscle strength assessed by hand grip, the muscle mass measured by appendicular skeletal muscle, or the physical performance assessed by the 6-meter walk test or a 5-time chair stand. More than 12 seconds if the patient can sit 5 sit-ups and sit-downs. Chair stand test is good. So,
just a reminder of the time.
Time is up.
Yes, but please continue.
Yeah, I'll wind up shortly. So, protein. Our protein usually for a healthy person it is zero negative balance. The protein intake should be, so if you take 70 grams protein daily, it has to be 70 grams protein out. So this is a daily recommendation for you. The usual conditions. The Aspen recommends 1.2 to 2 grams per kg per day of proteins. And for obesity, different numbers are there. And for ESPEN, 1.3 grams per kg per day. So how can we address for this sarcopenia? By oral nutrient supplementation or ONS. So everyone deserves a drink. So this oral nutrient supplementation will enhance the patient recovery, reduce the readmissions, increase the intake, improves, helps in increasing the weight gain, reduces mortality as well as reduces complications. So, what are the age interventions that has helped us in improving the sarcopenic patients? One is leucine supplementation. The breakdown of leucine results in the formation of hydroxymethyl butyrate as well as resistance training. So, what are the resistance training exercises? One is these TheraBand exercises, dumbbell exercises, pull-ups, push-ups, sit-ups, sit-downs. Actually, walking on plain surface actually does not count as resistance exercise. It's actually aerobic exercise. But these are all the ones that I mentioned earlier are the resistance exercises. So these three are the ones that are found to be helpful in prevention of sarcopenia. So lastly, my take-home messages are sarcopenia is much prevalent. It is if 50% is the incidence of sarcopenia in normal people. If we are 30 people here, 15 of us will be having sarcopenia. So sarcopenia is prevalent, and which is more so in the hospitalized, and resistance training and protein is the answer, and not just any protein. It has to be designer protein like leucine and hydroxymethyl butyrate, and not only during hospitalization, but at least for 24 weeks after hospitalization, you have to give protein supplementation. Thank you.
Thank you, Dr. Oni. It was very interesting. Is there any questions? Doctor, you can stop yours. Is there any questions from audience, or shall we move on to the next section? You can post in the chat box also. Doctor will be available after the session of.
Yeah, maybe one question can I ask?
Sure.
Thank you so much, doctor, for the valuable information. So regarding the muscle mass you were saying, so for example, elderly person, 75-year-old, if they are they have to undergo emergency open heart surgery or some kind of major surgery. So what is the minimum muscle mass they should be having, fit for the surgery? So what do you suggest for that? Elderly person who has to undergo an emergency surgery.
Emergency surgery, as you all know, whenever we are dealing with emergency resuscitation surgery, and our nutrition takes a backseat. That is a stage we have to do the surgery and recovering from the illness and start protein supplementation as early as within the first 24 to 48 hours. Go ahead and do the surgery and start supplementation by the Aspen and ESPEN recommends 24 to 48 hours starting, and start at 1.2 to 2 grams per kg per day.
And is it okay if they don't have the minimum muscle mass, even if it is an emergency? Like, is it safe to undergo a major surgery?
Definitely, that has an impact. That has an impact. But we don't have time to supplement, no, madam. We don't have time. So this is for the patient who is recovering from an illness where you can supplement the person. When in an emergency surgery, emergency medications takes a front seat. You need to emergently do if intestinal obstruction.
But maybe the risk factor might be more, no, in such cases. Yeah. Okay.
And
thank you so much.
The usual supplements provide usually, I think, 4 to 6 grams only. I think daily at least 12 to 16 grams of HMB needs to be supplemented for preventing sarcopenia. That is an issue that needs to be addressed.
Okay. Thank you so much. And it was very interesting session. From the basic, you were like taking us to the detailed things also. Thank you so much, Doctor, for your valuable time.
Thank you, Doctor. Doctor, there is a question in chat box from Ramya. This is Ramya Mahesh. How can we have assessments tools to check on lean muscle mass?
Lean muscle mass, again, it's again mid-arm circumference, calf circumference. Mid-arm circumference, often there's if the patient is an elderly and the muscles are hanging, should you tighten the tape too much, or should you loosen? No, you should not be doing like that. You just measure it as such as that. And calf circumference is coming in a good way. Measuring calf circumference and assessing for nutritional status. I think those two are the bedside clinic, simple clinical based measures that we can do. And definitely you can, for multiple things, we'll be doing a CT scan. Many patients will be doing a CT abdomen where you can, the skeletal mass index, SMI, skeletal mass index can be done, which is done at the level of L3. There's a simple software tool. If we discuss with the radiology team, they can interpret it, and you just quantify the skeletal mass index at the level of L3. That will tell you the mass index. And if you do a repeat scan after maybe a week, if there is significant fall in mass index by less than 0.5 centimeter, you are not going in the right way, that the patient is getting sarcopenic. CT, MRI, DEXA scan, bioelectrical impedance analysis, multiple things are there, but we can't, in our situation, we can't go for a CT scan just for assessing the muscle mass. So calf circumference or mid-arm circumference, anthropometric measures.
Thank you. Another question is from Mrs. Sheena. Is 13.5 fat-free mass is considered as sarcopenia?
13.5, according to the definition, it has to be.
Thank you, sir. I think there is no more questions. How to overcome this? She has asked that.
Overcoming sarcopenia. So as that's why I mentioned both age-related and disease-related takes a major hit when a patient lands up into the ICU. So start protein as early as possible. Try to increase on the protein intake, especially this leucine and HMB, and don't stop it. You even 12 weeks, you assess the muscle mass at 4 weeks, 8 weeks, and 12 weeks. You continue this ONS, oral nutrient supplementation, for a period of 12 weeks or 3 months.
Thank you, Doctor. I have one last question. Like, what is your opinion? Like, pre-operative nutritional assessments will reduce sarcopenia?
Obviously, all patients who are landing up in the hospital should be having their nutritional assessment by the Nutri-Score, MNS, all this scoring, Nutri-2, all this that has to be done.
Thank you so much.
And in my ICU, diet is being prescribed as a medication. It is written along with the medication chart. So daily for all patients, diet is being prescribed.
Okay.
I think in your places also it's like that. I presume.
Yes.
That much important. I think majority of the places, the treating clinicians are unaware of the importance of diet. In my hospital itself, in most of the wards, kitchen feeds are often being given regularly. So I usually go ahead and advocate regards to the importance of these fixed formulas.
Thank you, sir. Like, diet is taking good role in ICUs nowadays, and everyone is understanding the importance of diet and how important it is to like improve the malnourishment status of people. Thank you so much for this wonderful, insightful presentation. We hope you stay on with us for another session on dysphagia. I welcome Ms. Uma Kalyani, our president, to introduce Dr. Priyanka Rohatgi.
Hello, good evening all.
Sir, you can
Dr. Priyanka,
one second, Uma. Sir, you can stay on for a few minutes so that I can add Priyanka and we can have a small screenshot also. Uma, you can continue.
I hope Dr. Priyanka has joined, Sripriya.
Yes, yes.
Yes, I'm there since the beginning.
Ma'am, can you, is it possible to open your video?
Can you see me? Yeah.
Yes, ma'am.
Yeah.
Continue, ma'am.
Okay, fine. Hi, Dr. Priyanka. I'm very happy and delighted to welcome Dr. Priyanka Rohatgi today. She's a founder, director, and venture partner at Concurrent Nutrition Enterprises. And she has over 23 years of experience in the field of clinical dietetics and nutrition research. And she was a former chief clinical dietitian and head of department for almost 2 decades at Apollo Hospitals, Bangalore. I hope you remember me, Priyanka. During the initial days, like we have gone together for the IDA meetings. So she was a president of IDA Bangalore chapter from 2011 to 2014. And she has got so many awards under her credit, under 45 Healthcare Change Makers Award in 2024. She has got from AIMS, New Delhi, and faculty for online programs and different nutrition courses. And she has got 8 gold medals to her credit, awarded with international award from UK Emerald Group for the best scientific work to the for the year 2007, and green belt in Six Sigma certification she has got, an expert member of DSMB of Cornell University, USA. And she has contributed many articles both in newspaper as well as the print medias. 55 plus research publications to her credit, and journals and different journals and nutrition publications. And she was she has gone as invited speaker on many forums like IDA, ISPEN, IAPN, and so many RSSDI and so many other conferences as well. And I hope now Priyanka is in USA, right?
Yes.
Yeah. So, in spite of the time zone difference, she has shown her kind-heartedness to join us for the session, and I'm welcoming on behalf of CNF. Well, over to you, Priyanka.
Thank you so much. And I think you guys are doing a phenomenal job in spreading the right awareness. And I can see great participants. I can see a lot of my friends from India, Qatar, Dubai, Nepal, and other places who've joined. Thank you so much. Dr. UNNIKRISHNAN has done a fantastic job in taking us through very, very simple ways in which we can manage, the sarcopenia. I'm talking on the other spectrum. I hope the slides are visible. Can you see the slides?
No, ma'am.
Not it.
This morning also we had some glitch in another presentation, so I hope it. Are they visible now?
Not it open, Priyanka.
It's moving fine for me.
Okay, let me try, ma'am.
Should I stop sharing?
Yes. One second.
So while we get the slides, I'd like to take you through the dysphagia challenges that we dietitians face. This is one of the leading contributors of sarcopenia because we just are unable to meet up the requirements. When we started our career way back, there were these national dysphagia diet guidelines which we were using, which were very difficult to interpret. Luckily, now we have the IFCCM guidelines, which I'm going to talk about. But before that, I'd like to take you through a little bit on dysphagia. Yes, thank you so much for this. We could move to the next slide. So dysphagia is a physiological problem where we find that there is a difficulty in deglutition. So there is swallowing challenge, and it is very difficult for patients to take the food down. And the pictorial depiction shows us why physiologically this challenge is happening. Next slide, please. It can present to you in your OPD in many phases. So you could have an elderly patient, you could have a person with COPD who has coughing difficulty, swallowing difficulty. Depression is one of the reasons why people pocket a lot of food. They have the fear that they will drool out the food. So we have to understand that we have to use food here as a medicine. It's very, very important that these people are given enough confidence that yes, we would be able to come out of this physiological challenge and make them a part of the social gatherings. This should not be a taboo that people who have dysphagia, when they go out, it would be embarrassing and things like that. This brings about a lot of discouragement. Now, depression is one of the strongest reasons which I have seen very profoundly here also in US, because the family support is very, very less. In India, luckily, this is there, but family supports covers it. And to a great extent, this may also go unidentified. So when they come to your OPD asking this question, or when you see them in the ICU bedside or in the rooms, it is very important for us to identify this and tackle it right at the initiation. Next slide, please. So looking at what could be the associated reasons, there are many, many reasons which could be associated due to medical conditions like Parkinson's, different kinds of tumors, head and neck cancer. There could be pharmacological reasons. There could be scleroderma. There could be some foreign body stuck, so on and so forth. So there are so many reasons. So when you have these kind of diagnoses coming to you as patients in the inpatient or outpatient, we must have a red flag alerted that they could be presenting or getting into dysphagia. Next slide, please. Next slide, please.
Is that no? Yeah.
You could go on. Yeah. Now, here, this is a prevalence chart that I've taken from the European Society, where clearly we see a lot of these dysphagia patients. And interestingly, 15% of them exist in the community which go undiagnosed. So many people just don't understand. They are living isolated or in assisted living, and they don't understand that this is the problem and they're constantly losing weight. Unfortunately, if they present with other comorbids like Parkinson's or Alzheimer's or any kind of cancers, this can worsen the disease condition. Nearly 50% of them get to the nursing home where you don't have a dietitian, or you may have very limited access. Only 12 to 49% are diagnosed in a hospital. So we are actually looking at the tip of the iceberg where only 50% patients are identified. Next slide, please. So our goals are initially to provide the airway protection to prevent aspiration. So it's very important we assess the texture and the viscosity of the diet that we are giving. We have to maintain our dietary guidelines in terms of optimal feeding to such patients, maintaining a balance sheet, giving them the confidence of living a good quality of life, enjoying the pleasure of eating, and address the secondary complications. Next slide, please. So there are a lot of these nerves which are involved in the dysphagia process. So swallowing requires your 6 cranial nerves, your 4 cervical nerves, and 30 pairs of muscles. So any problem among any of these 40 functional units can lead to the problem. So we can identify with the help of the clinical team, or if you have a speech and swallow therapist in your unit, it could be oropharyngeal, esophageal, or pharyngeal. So once you identify the problem, it becomes a little easy for you to plan and understand the texture. Next slide, please. Now we understand clearly that when a nursing assessment is done, there is an inability to swallow. They may say that I experience a little pain or discomfort, or immediately while they take something, even a sip of coffee or tea, they have a gag reflux and they cough it out. There is hoarseness of voice, there is a regurgitation, there is a sensation of food being stuck in the esophagus, and you could see fluid or swallow or the saliva drooling out, and there is a visible weight loss and frequent heartburn. Next slide, please. Now we have to address the ABCs. First is aspiration, because if they are elderly patient, we don't want them to land up in any lung infection or pneumonia or any kind of aspiration related infection. So we have to make sure that the airway is clear. We have to make sure we address the nutritional part of it. Most of the times only juices or maybe plain milk is given to them, which does not fulfill their requirements. And there is instability in their blood sugar levels. There's electrolyte imbalance, which could further lead to delirium, and they could have falls, and then that could worsen the further problem. They also are dehydrated to a greater extent. Next slide, please. Now, when we look at the symptoms, we would see them pocketing food. There is a gargle voice or a slurred speech when they're talking or eating food. When family members are talking to them over phone, they would observe that there is a change in speech. Clearing of the throat after swallowing, drooling, coughing, choking, complaints of chest pain with swallowing, refusal to eat or drink, eating very, very slowly when everybody else has eaten the food. They take almost an hour to finish. Excessive amount of chewing and effort, and there's loss of food or liquid while eating or drinking, and there's upper respiratory tract infections. Next slide, please. Now, what are the interventions? I won't get into the medical or nursing interventions because they are generally taken care of by the team who's working with us. Next slide, please. Now, looking at how we could modify. So this was initially when we all started our career way back. These were the kind of diet plans which were given to us from the National Dysphagia Diet, which was very difficult. Number one, they were very westernized. So they would just talk about applesauce and, cream of potatoes or cream of different kinds of soups, which was not practical in the Indian scenario. Next slide, please. Then came the IFCCMM guidelines. IFCCMM guidelines is very, very beautifully designed, and I would request all of you to get onto the IFCCMM website. The pictorials are phenomenal. The way they take us through the stepwise approach in handling dysphagia and explaining it to the caregivers is phenomenal. I'll take you through those, but I would request all of you to kindly incorporate this in your diet plans for dysphagia. Now, this is the same kind of food which can be modified into different textures. So you have a piece of meat or chicken, you have some vegetables, and you have some carbohydrate. These could all be minced nicely into various textures depending on the IFCCMM guidelines, the numbering of the guidelines, which we would cover now, to understand how texture and things can be modified. When you look at this framework, this is evidence-based. This gives you a lot of flexibility in terms of international and intercultural foods. So we could adapt it to an African menu, to an Indian menu, to an Asian menu, to a Japanese menu, to so on and so forth. They talk about the common language of texture, fluid, and viscosity, broadly supported with lots of pictorials and a lot of education material available, strongly supported with operational definitions. Next slide, please. Yeah, we could go further. So here, if you look at the site, you would see that they define each food into various categories, like starting from 0, which is thin, to slightly thick, to mildly thick, and each one has a very clear-cut definition of its texture. Next slide, please. So we no longer use the NDT diet, which is very difficult to interpret. We should all now move on to IFCCMM guidelines and make them a part of our OPD or IPD charts. Next slide, please. So here, taking simple examples like what is thin, what is thick, you could see them. When you say mildly thick, things which can be taken through a straw. And you could define your food items depending on the kind of client you have, from South India, from North India, from Eastern India. So you could clearly, list out the food items for them, which makes it very simple for them to understand. Next slide, please.
Slide is taking little time to move. Once again.
No problem. Now, when we come to moderately thick, these are things which can be taken in a cup or a spoon. So you could mince your curd rice, you could mince your rava porridge nicely to a texture which can be held in a spoon and eaten. So this way it gives us a very clear-cut definition, and especially for hospital dietitians who have to instruct the F&B staff, this becomes very easy when you put the chart in your dishing out area so that they also understand this is the kind of food that has to be supplied to the patient. Next slide, please. Now, there is another thing called the flow test in that. So you have a few materials available from them, starting from a syringe to a chart which has different circles listed on it. Now, when you discharge the food item from the syringe, the level at which it takes in the circle, the diameter that it covers in the circle, will give you a very clear-cut idea on the viscosity and the texture and the thickness of the food. So that way we could have standard guidelines for our post-op patients, ICU patients, so that we know at what level we are starting, and we can prevent a lot of aspiration and prevent a lot of underfeeding in such cases. Next slide, please. Now, taking through everything, there were pictures here. I don't know why I'm not able to see them. So smooth food, yeah, like this. So same food which is cooked in the kitchen can have different textures for different patients, but these have to be instructed. And IFCCM guidelines tells you very clearly what should be the particle size, say for an adult, 4 mm, for a child, 2 mm, something which just gets into your mouth, does not require biting, but a minimal amount of chewing, which can easily be swallowed, which can be eaten through a fork, but you don't really need to press it a lot with the fork. This would be the definition of minced and moist. Next. We can actually run through quickly because these are self-explanatory, soft bite-sized foods. Same food which is cooked in the kitchen, a slight texture change can give you a lot of options in your patient pool. Next slide, please. This is another example of easy to chew. So this is a nice soft egg done to order, or a nice fish which is cooked, which is very easy to just take it as a finger food and eat. So these kind of definitions are very important. Next. Then comes the transitional food. Now here is the patient getting ready to go home, get discharged. So we have to make sure that each transition is explained with the pictorial depiction to the patient so that the caregiver has a clarity. Sometimes the caregiver could just be a home nurse or a home attendant. So if you have pictures available, it's easy for them to instruct the person who's cooking food for the patient. Next slide, please. Standardized food testing methods, tablespoons. So this is how it was earlier. Next, this is how it is now. Next slide, please. We could, yeah, continue. So we have to make sure that, first of all, our illustrations are clear enough. We explain them about small and frequent eating, ensure that enough hydration and nutrient optimization is done for such patients. They should be weighed on a weekly basis. There is enough variety. The same home food which is cooked is done into different textures for them to eat and relish along with the family. Next slide, please. The texture modified foods in different plates. Next slide, please. Next slide. Yeah, we can skip this as well. Now, you also find these days, we can hold on here, these days a lot of thicken liquids. So you get powders in the market which could actually thicken a drink in the house which is prepared, maybe a fruit juice, a pineapple juice, or a watermelon juice. And if the patient wants to relish, you just add a teaspoon of that powder. There's one from Nestle which is called Thicken Up. There are others which are coming in. There are lots available in the Western market and in markets of Sri Lanka, Malaysia, etc. What we need to understand as dietitians is, number one, is that powder contributing to a lot of thickness and confusion? So then you need to standardize in terms of scoop sizes. Also, is it very bulky? Is it adding to a lot of bulk and discouraging the patient to eat the standard portions? Number three, what is the composition of the powder? Some of them are just fiber supplements. So they do not add to satiety, but they are just adding to the texture. They're pectin containing or amylopectin containing. So they just add to the texture. Next slide, please. Cost is another very important factor because they are already on recurring hospital visits, and they may be on medication, supplements, etc. So are we able to afford that additional cost of the thickening fluids? That has to be taken into account. Are they available easily in your nearby market? Next slide, please. So keeping all that in mind, we need to understand that if we have to pick up something for our patient, number one, we follow the IFCCM guidelines with clear pictorials and illustrations so that it's easy for them to stick to home optimized meals. If we have to supplement, look at the various composition, the nutrient content of the product that you're using. Is there a variance? Is there excessive thickness, convenience, and things like that? Next slide, please. And classify them clearly as to what do you mean when you say a certain liquid texture. Next slide, please. Performance characteristics of bolus feedings. When you are giving them, it is very important that when we add any of these thickeners, if they are modified cornstarch or xanthan gum, if they are indigestible to the body, are they adding to the bloating? So that is something that has to be looked at. Next slide, please. Also, if there is bolus modification, can they be used in all kinds of temperatures of the food? Sometimes they become bulky and lumpy, so you may not be able to use. If they are changing the color and texture of the beverage or the food, it can be a discouragement for people to consume that. Next slide, please. Currently, the ones in the market are slightly expensive, so we need to see that as well. There's also something called thin water protocol. You'll find more details on the IFCCM website for that, which gives us the water protocol of the viscosity of different kinds of fluids. This is something important for us to know because the liquids are the ones which immediately cause the gag reflux and they aspirate among elderly. Next slide, please. When we want to keep them well hydrated, we need to make sure that we follow the thin water protocol and ensure that 60 to 70% of the fluid requirements are fully met. Next slide, please. Yeah. Thin water protocol is also useful, but it is not for everyone. It is generally for elderly people and people who are dehydrated. So we can assess and decide whom do we want to educate this on. Next slide, please. And then there are texture modified liquids for dysphagia diet. These were traditionally followed. Now, if you follow the IFCCM guidelines, you don't really have to put all these things into your diet plan. Next slide, please. You also have something called the IFCCM newsletter, which is the e-bite. I don't want to sound like a promotional ambassador for IFCCM, but it has made things very simple for us dietitians to educate our patients on dysphagia. Next slide. These are some of the references that I had used. And if there are any questions, thank you.
Thank you, ma'am. Shall I stop screen? Thank you, Dr. Priyanka. It was a very interesting session. Is there any questions? You can post your sessions in chat box also.
Thank you so much, dear Priyanka. It was very, very simple manner. You explained everything, how to modify the consistency or the texture of the food without compromising on the nutritional qualities. And I think the same method or the techniques can be used as when we use the food as weaning foods, right?
Absolutely. There, the challenge is not so much because, the mother is constantly monitoring. But in case of elderly, people don't monitor their food intake. So in the European countries and in the Western countries, we have something called the protected meal timings, which is a very nice concept in the hospitals. Here, because the staff is very less, you don't have full-time dietitians, you have very minimal nursing staff. So one of us takes turns and supervises while the patient is eating food. It could be anybody from any department, which is called as protected meal timings. And we document how, patients are eating or if they're facing any challenges.
That's great. Okay. Thank you, ma'am. We don't see much questions from the chat box also. What is the
There's one question now.
one question? What is the best protein brand for children with autism and dysphagia?
Generally, you don't find dysphagia with autism. They're hyperactive and feeding may not be a major challenge, but yes, limiting the sugar. And some patients have benefited with limiting and addressing the leaky gut. So they benefit out of omega-3 and probiotics being used. Sugar should be something which should be limited, not in the, should not be given in the direct form, and choose food as finger food with complex carbohydrate, good protein, so that we could stabilize the activity.
The session was quite interesting. We had a good number of participants, and because it is like a week, like we had a long weekend after postmortem, so the participants must be traveling. So there is very like network issue and side of things. We are not seeing many questions. Is there any other questions from Dr. Unni or to Priyanka or anything like that? Thank you, ma'am. Thank you, Dr. UNNIKRISHNAN. Thank you both of you for in Community Nutrition Forum, we are doing every month continuous nutrition education programs. And basically what we do is the Dietopedia is for dietitians by dietitians concept. Basically we do. And on the special events and special occasions, we call other interdisciplinary people, healthcare representatives to give us a sessions also. So this time we thought of doing something on critical care as well as anabolic health. So I'm very thankful. Sorry, there is 2 more questions. I think we can quickly do that also. Dr. Unni, why body jerk happens? This is addressing to Dr. Unni. I think he is not able to hear. Priyanka ma'am. Okay. So there is a question for you, sir. Why body jerk happens?
Why?
Body jerk happens.
Why body jerk happens? Because of malnutrition. That's what they're asking. Because body jerk happens usually, especially in patients, chronic kidney disease patients. I will take CKD patients, for example. CKD patients who are on long-term dialysis, who are on aggressive dialysis, lose potassium from their muscles. Usually when there is loss of intracellular potassium from the muscles, that is when cramps, that is what we usually say as cramps. That is a usual one of the conditions, because of already the patients are elderly, lean, critical illness, along with if the patient has a comorbidity like a CKD, aggressive dialysis. This is just an example that I mentioned, and multiple other causes like seizures. All these are usually described as jerks, myoclonic jerks. Different causes are there, but related to nutrition, I think hypokalemia is one of the causes of weakness and jerks.
Thank you, sir. So it is time we can wind up our session. It's already 8:30, and for Priyanka ma'am, it is a very tiring session, and Dr. Uli also, it is a late evening, and Priyanka ma'am, it's early morning. So thank you both of you. Like I sincerely thank both of you for immediately accepting our, I was very late in calling you also. Just I think 20 days time I called both of you. Thank you for accepting this and making the event wonderful with your insightful knowledge and wonderful session and presentation skills. And all the slides were very beautifully designed and like easy to read also. Thank you both of you in this. And I sincerely thank our team members, our President Sharon ma'am and Joint Secretary Sonia couldn't join us today, but our Vice President and Treasurer is here with me. Thank you, Uma, and thank you, Jyoti, for wonderfully organizing our session as usual. And thank you, the other executive board members, as well as our Meraki wonderful research team. And thank you all the participants, because that is the very important. Unless you participate, we cannot continue with the sessions. Like Dr. Bunny was mentioning, our success is just because there are so good number of till date, we are getting always 40 to 50 members joining us every month by month. Thank you all of you in joining us. And we'll meet again in next Dietopedia. Maybe the another mass event will be like going to happen next immediate week. That is for the Meraki Researchopedia. It is on sports nutrition. If possible, everyone join in that. We'll be sending the links shortly. Thank you all.
Thank you. Thank you so much, everyone.